Welcome. Thank you for joining us for tonight's educational webinar, When Your Knee Pain is Just Too Much. Tonight's speaker is Dr. Mark Gittins. Dr. Gittins is a board-certified orthopedic surgeon at OrthoNeuro who specializes in sports medicine and arthritis. He has extensive experience in outpatient hip and knee joint reconstruction, including robotic-assisted knee joint replacement surgery. Dr. Gittins will answer questions following his presentation. Please type your questions into the Q&A box at the bottom of your screen. Dr. Gittins?
Thank you, Heather, and hopefully you all can see my screen. How's that coming across? Okay, everybody?
Yep, you're good.
Okay, so I'm going to talk to you a little bit about knee and some of the things that we offer in knee and some of the new stuff. So it's going to be a little bit of a data dump, something that I find exciting, but then I'm going to show you some of the current research that we do out of the Orthopedic Foundation and here things that we do at New Albany that are somewhat new. People are always asking me in the office, what's new? What's the latest? Is it too early? Am I ready for what I need? Is something coming on the horizon? So I'm going to share some of that with you. And then we're just going to be able to talk at the end of it. You can put your questions in the Q&A and I'll be able to hopefully answer any of those. So again, I am a hip and knee surgeon. We're initially going to just talk about how your knee kind of works, some basic guidelines, knee replacement issues, things that we can do before knee replacement, what patients have. And then I'm going to show you a couple little videos of some of the newer technology and how we do things. So the most common thing we see is osteoarthritis, which is good old-fashioned wear and tear arthritis. That's different than rheumatoid arthritis, but really it's the damage, excuse me, it's the damage, excuse me, of the hyaline cartilage, which is the end of the bone. And that's what we replace when we do knee replacements. We don't cut out the whole knee joint anymore. We replace this hyaline cartilage in the areas where the meniscus was. So it's a little different than what a lot of people think. But as we go through aging and our surfaces in our body change with year to year, decade to decade, these things tend to degenerate. It is very common that we do get this degeneration. One of the studies was over 46%. There are some other ones that are up to 52%. So over half the people in the United States suffer with arthritis. We've seen an advancement and progression of the arthritis secondary to the obesity problem that we have as well. It is the most common disability that we see is osteoarthritis. So we have stages of it. You just don't come in and have the worst arthritis. It happens over years. And so let's just use something like mild, moderate, and severe. Mild, you start to get some aching with heavier use or stair climbing. You can get some chronic knee pain and stiffness. You may limp if you've overdone it or played some soccer with the kids or something like that. That's a sign of arthritis. You may notice that you're not able to be as flexible as you once were. You're not able to bend or put your shoes on or squat down as much. You may get some swelling. You may start to notice, or somebody in your family notices, that you're walking different and that you may be more bow leg or knock knee. Those are type things. You may be able to feel things on your knees that weren't there in the past. They're a little more rough. And those are all kind of things that we see in the progression of the disease. But again, it doesn't happen instantaneously. You may only get pain in your world very quickly, but the disease has been going on for some time. Again, if you look at some of the mild parts, again, those are something early, younger in life, minor defects. And this is what it would look like over here. Hardly any changes in this kind of silvery hyaline cartilage. When you go to the moderate stage, okay, perhaps more pain, starting to lose a little bit of flexibility, can't squat quite as far. You may not be able to run anymore. It's like, well, I was able to run in my 20s and 30s, but now in my 50s and 60s, I can't run. Something like that is a transition we see as the arthritis progresses. The late stage severe, again, you can get deformity. You've lost lots of hyaline cartilage. You're basically starting to become bone on bone at that point. Why is it bone on bone? Because you've worn off the hyaline cartilage. Again, you have difficulty with stair climbing, doing activities of daily living. You have difficulties even getting sleep at night, secondary to discomfort. Things we know when we are seeing something early, we put people in physical therapy. Most of the insurance companies want to see that you've gone through a therapy program before they do anything else. You can try ice, you can try heat. Those are both helpful. And then there's no wrong or right one, ice or heat. It's really whichever your joint feels better with. You can try over-the-counter medications such as Advil, Aleve, Tylenol is something you can use as well. These all help as much as anything else. And oftentimes we'll recommend that you alter and alternate perhaps the anti-inflammatory medications with the Tylenol. Nutritional supplements, kind of an iffy topic. You see some ads sometimes on the TV and the radio with people trying to promote these things, usually non-surgical people. There's really been no clinical study that I know of that shows that the things such as glucosamine have produced very high results in all people. There's the case of 1 or 2 people, but it's really not recommended by the Academy of Orthopedic Surgeons. 3 out of 4 patients continue to progress even at these early stage. So one of the things that we can try to do is to do injections. We use the Advil, the Aleve, we do the physical therapy. One of the injections that we use is a lubricant. You may hear about that, called a viscosupplementation lubricant. And basically that's just a real thick gel that we inject into the joint. We are finding with the current research that there's less and less opportunity for corticosteroid injections, the cortisones and the steroid injections into the knee joint. We used to see that all the time. It's what we did 20 and 30 years ago, but now we're seeing some deleterious effects. It can actually advance your arthritis. It can increase your osteoporosis. It certainly can increase your infection rates as well if you do have to have surgical intervention. So we're kind of shying away from that a little bit. And if anything, we're maybe going to this thicker type of gel injections. The statistics on these thicker gel injections are about 70%. So 7 out of 10 people get better. 3 out of 10, it doesn't change anything for them. Other things that are really important is make sure that your BMI, which stands for body mass index, is under 40. We can't really even do anything anymore with the insurance companies unless we get this weight challenge under control. Simultaneously, if there's a diabetic issue, we need to have something called the hemoglobin A1C less than 7. We can continue to use the armamentarium of different medications and perhaps alternating them. Instead of perhaps running, we maybe go to the pool where we alternate our activities so that we just don't keep doing the same thing on the joint. Surgery, again, we always recommend last after we've done all the easy and preliminary choices of care. So when you think about things in your mobility, again, I was kind of discussing that you may have loss of that. You know, how fast can you walk? How far is your stride? How about bending at the hips and knees? Can you squat all the way down to tie your shoe? Or can you squat all the way down like you used to? Some people get difficulty even driving. It's like they have trouble changing the gas pedal to the brake pedal. On your golf swing, can you spin? Can you spin? Can you swing? Can you do yard work like you used to do? Those are things that we look for and ask. So those are things you can think about. If they're being altered, you may be someone who is considering that you have some type of arthritis. So here are some of the surgical options when we go through those non-surgical things. We always want to try those first. First thing is an arthroscopy. Again, that's in the mild stages of arthritis. Arthroscopy, as a rule, though, is really not a great treatment doing scopes on the knee or doing arthroscopies for arthritis. It is really good for ACL reconstructions. It's really good for meniscus tears. It's only really helpful in arthritis is if there is a flap or mechanical lesion, something that's mechanical in the joint. But if it's just arthritis and you want them to smooth it out or clean out their arthritis, it really doesn't have good long-term benefits. Other options, depending on the pattern, which is what we now are looking at, the patterns of arthritis for that specific individual, is you can look at some robotic surgeries, which we tend to specialize on partial knee replacements, only working on the area that is really diseased. And then for people that are deformed and have ligament balance issues, then you can obviously do the total knee replacement. But again, remember what total knee replacement is only replacing what has been worn off, this white part. We don't cut out the whole knee joint anymore. So has this happened to a lot of people? It happens to a lot of people. So you're seeing 500,000 knee replacements in the United States. The baby boomers have continued to increase their activity levels. They don't want to stop. They don't want to slow down. They don't want to live in pain. They want to work. They want to recreate. And so we're all about trying to help them that. So there's 500,000 people that are each year that are getting new knee replacements. And we're seeing, 94 to 96% success rates in those. Things you got to know about when you're considering surgery. Again, something you should discuss with your family and your surgeons. You need to look at your age, your weight, your activity, modifying activities that could put you at risk, such as injections, elevated BMI or body mass index, skin lesions, psoriasis lesions, diabetes management, all those things you want to optimize so that you're having easier recovery. The nice thing is, though, these are all now outpatient surgery. So all the knee replacements now that we do, no matter which type, are outpatients. And that's actually done this way by the federal government through CMS, Center of Medicare and Medicaid Services. I can talk to you a little bit, and I'll show you a video of how this is really done now in an outpatient world, which is probably more important now than it ever has been, with the crisis that we're all enduring at this point. Early diagnosis is important. If you do have mild arthritis, you want to start trying to take care of and extend it. There is no cure for arthritis. We cannot make the hands of time go backwards. Some people, and we've really seen this with the COVID SARS 2019 crisis, is people are delaying their knee replacements, and we're finding out that that's a bad thing. It's deleterious. So when you start to hurt and you're having a problem, waiting doesn't help you. What happens is 2 months, 3 months, 6 months, it's people that have had this and have been waiting since March, they're really in bad shape at this point. So when your time comes up, it's better to get it treated versus delaying treatment, because you'll be able to take advantage of the new condition, and your recovery is actually easier. And if you think about it, if you've been waiting since March till now you think you want to get your knee done, which we're seeing, you're still in arthritic shape, and you've wasted all that time and couldn't participate. Whereas in 3 to 6 weeks, you could be back in playing golf. Again, make sure that you optimize yourself. As we all go through life, you're always going to be healthier at 20-year-old than if you are at 60, 70, or 80 years old. So if you do have the arthritis and you finally get to bone on bone and you're having pain, it's better to consider getting things done at that time versus trying to delay. It does not get better. Again, just some illustrations on that. So the minimally invasive surgery, a lot of people like to talk about that. That's probably the best thing we can do with the robots. And so that's something we've specialized in. I think the robots really give us a lot of accuracy and the ability to reproduce the cases. It really makes it a lot easier, customized for each patient. Here's an example of one of the robots that we use. And I'm going to show you a quick little video of how this actually works. So instantaneously, we can put a knee up onto the screen, and this is what the robot looks like. And it talks to the robot, to this handpiece, and then it's able to control how we shape the knee to work with the surgeon's hand. So it's not just the robot works; it's the surgeon and the robot working together to get this result. These are kind of the ways that it's able to do this. And we see the damaged cartilage, and the robot goes in there in a mini type of way and removes the damaged area and then puts onto the implant. So it makes us much more precise than the old instruments. Here's an example of where you can see that in a graphic situation where the robot comes in. Here's the knee right here. We map it up onto the screen with real-time data. And this is different for each person. Takes us a few minutes. Then we can actually simulate what the knee is going to look like before we even make any cuts on the bone. So we can see how it's going to work, how it's going to bend, where it's tight at 30 degrees or 60 degrees. And we can alter the placements to try to get this so it's perfect for each individual person. That information then goes into this machine. This is part of the robot, and you can see it goes in and out and cuts more or less depending on where the need is. Once the robot approaches the bone, it knows the pattern. It already knows which way it's going to cut, and it makes this resection of bone in a perfect fashion so that the knee is perfectly balanced, and it fits as if you never had arthritis before as far as the correction and the balance. So the implants go in, they're cemented in, Again, these are outpatient surgeries. You can see the implant go in, it's cemented, and the knee starts bending. We have people walking within an hour, going up and down stairs within 90 minutes after the surgery. So it's very, very accurate on how these new technologies work. This is what the x-rays look like afterwards. You can see everything is perfectly spaced across there. If you're candidate for these type of procedures, your knee works better, functions better, and lasts longer. So there's a lot of less damage. We think we minimize any damage to the soft tissue, and we think we get a better functional result. You can also have special x-rays. That's what this slide is showing you. This is slowly kind of edging out because the robots are taking over, and you don't have to go get special x-rays such as CAT scans and MRI scans prior to your surgery. But with that, you can get these new implants that fit and rotate just perfectly on your individual knee. There is a little bit of a gender difference. So how do we see men compared to women? Women tend to have more disability. Part of that reason is because they are usually the last ones in the household to get their treatment. They get everyone else in the family taken care of, and then they're last. So as I was saying, they've waited longer, therefore their disability is higher. They have higher pain. So again, that's something we take into account, and we try to get these people in and back to their lifestyle, to dancing, to hiking, whatever they like to do, just be able to sleep at night without pain. Again, knowing the specific anatomy of a person, whether it's man or female, and putting it into the robot has been a big help. So if you start having questions, you can start putting them in the Q&A session right now, and I will get to them. I'm going to show you a couple of other quick little things. Everyone wants to know about the latest technology. So here's some of the latest technology. This is out of a company that I consult with, and I work with the Orthopedic Foundation. This is an Ohio company that, if you're an Ohioan, you should be very proud of. So you hear about 3D printing all the time, and this is how we use some 3D printing and able to come up with some of the best components now in a creative fashion. Classically, this has been what we call subtractive manufacturing. So when you made these implants for knees and hips, you would just cut away pieces of metal and then put it in. This is the opposite. We add to the metal and then come up with a unique idea. So that's what 3D printing is. It's called additive manufacturing. We 3D print it. This is what they look like when they're done. Here's a standard machine cup. So this is an acetabular cup, but it's just been made by cutting bone away. Whereas this one was created, you can see it's different. The sizes of the holes or the pores are different. That's something we can create because we can dream it up. You can't do that any other way. These are just sprayed on with a spray gun. We got these little fins in here that we can make. Lots of really interesting creative idea. Again, an Ohio company that's come up with this, and this is what the whole construct can look like. You can see this has all been 3D printed and made to fit a person. Here's a side-to-side comparison. This is traditional on the top row and how it's all made. Here's the bottom row of how we do it with additive manufacturing and 3D printing. So we design the implants, we analyze them with the robots, and then we start generating what we want to do with them. Here's again, subtractive manufacturing on the top. It comes in with a piece of bar, and then we just cut away what we don't want and end up with a cup. Whereas the other one, we come in with a powder, and then we create the bar or create that. So I'll show you a quick little piece where we had this powder, which is the same as the titanium, but we're able to create more things with it by going through all these different printers. So here's a knee, and this is, we're printing a knee and a hip at the same time. So you can see this one's not all the way done. They stopped the printer, but we can just create and grow these any way we would like to. And then this is what it looks like in real time. Hopefully we can show this. So this is what the cup looks like and how we make the cup. And again, this is just how it's grown through this special computer. And we just put powder on it, and then it tends, there's the powder going in, and then it grows the implant. And again, we design this specifically for each person with a specific millimeter, 48 millimeters, 50 millimeters. And then this laser goes over the top of it. Each time the laser goes off, it adds another micro layer of the titanium, and we come up with a new part. So that's how it looks like when it comes out. Then we blow off the old titanium, and there's the brand new cups for the person. So pretty interesting technology. Oops, I lost some of it here. Apologize. See if I can get it to go back. It's not letting me go through it. All right, so that is how we're doing the 3D printing. There's a couple other slides, but it's not letting me show you. So the next talk I'm going to show you is this outpatient talk. I wanted to show you the last line, and this is what the 3D printing again looks like. We're able to, it comes out in a purple color. This is what the titanium looks like afterwards. It's really amazing technology that we're able to put it through the process, and the 3D printers are able to create these implants specifically for everyone. Very interesting. So now I'm going to talk to you about, this is outpatient surgery. So we've been doing outpatient surgery for about 10 years. And we're finding out that it's really important right now. And the reason is because of the COVID crisis. And computer's going wacky here. 1 second here. All these different talks. And so we've been doing this 10 years. Why were we doing it 10 years ago before the COVID crisis occurred?
Well, I have had a history of orthopedic problems in my lower limbs for a long time. When I followed up with Dr. Gittins, then I found out that arthritis. Well, I have had a history of my hip as well. Gradually, I have just, been less active. And then a couple years ago, I retired. And so now I want to be able to do the things that I want to do when I want to do them, and it's just not as easy to do that right now.
Being outpatient, there's a lot of benefits to it, and you're in and out. You're back in your own comfortable bed or back in your home. So I think the healing process just is that much easier for you when you're at.
I apologize here. I've got so many videos. Let's see if I can get this to open up. Here you go. So this is outpatients and why we believe so strongly.
Well, I have had a history of orthopedic problems in my lower limbs for a long time. When I followed up with Dr. Gittins, then I found out that arthritis had really started affecting my hip as well. Gradually, I have just, been less active. And then a couple years ago, I retired. And so now I want to be able to do the things that I want to do when I want to do them, and it's just not as easy to do that right now.
Being outpatient, there's a lot of benefits to it, and you're in and out. You're back in your own comfortable bed or back in your home, so I think the healing process just is that much easier for you when you're at home.
Hey, I'm all for outpatient. Yeah. What I'm expecting today is to go home for lunch, and I think everything will go very smoothly, and I've been looking forward to this, so I'm ready to get started.
Just to recap what we talked about in the office, anesthesia will be in, Dr. Betts and his team will be in just a little bit. They're going to talk to you about a number of different things for this. We just completed the right toe lift on an outpatient basis. Everything went smooth.
Okay, I'm going to sit you up a little bit. You did great. How's that hip feel? You having any pain? Surgical leg in, good leg. So we're going to go up with the good. Yep. Very good. Again.
Superstar. I love it. A plus. Excellent. Good.
I'm not at all hesitant to go home and think that I'm going to have any kind of a medical emergency. They did not push me out the door when I faltered a little bit. They just held steady right there until I was ready to go to the next step, and that's what happened. I'm looking forward to going home, getting comfortable, and just letting the recovery stop.
So that's an example of our outpatient world. And again, we think this is better for a number of reasons. Certainly the patients just do better. And again, we've done it this way for 10 years. And now and we have visitors from all over, some virtual, some in person, trying to figure out how we've been able to do this so well. That video that I showed there is one I actually showed at Medicare and Medicaid Services, CMS. I went there and was fortunate enough to testify to them on that this was safe and that you could do it this way. And so it's certainly the way that we thought it was needing to be trended. And then with the crisis and the viral crisis, certainly we don't want people going to the nursing homes. We don't want people going to ICUs or even going to hospitals. Come in, get your case done. And you kept hearing, you'll be home by lunch. So we feel very confident we can do that safely and actually have a better result, less pain, and less overall complication rate, and just a better overall result when you see how far the knee bends and how happy the patient is. So with that, if you have any questions, you can go ahead and put them in the Q&A system. And so I'm going to try to answer some of the questions. The first question is, will the insurance pay for the gel shot? And so the answer is most of the insurances do pay for the gel shots. It has to be pre-certified. And so we have to call the insurance company and tell them what you've been through. There are some prerequisites on certain insurance companies to get gel shots and visco supplementation. And so if we haven't done those things, we pretty much know the questions the insurance company is going to ask on what you've tried. And so if you haven't done them, we may ask you to do them just so that if you do fail those, that we can go into the gel shots. The biggest insurer that I know that struggles, not all the time, but seems to struggle the most at approving the visco supplementation of the gel shots would be Anthem Blue Cross Blue Shield. I'm able to do it some of the time, but it's the one that seems to be the most prickly about that. So hopefully that answers your questions. If you have other questions, you can go ahead and type them in to the Q&A. So the next question is about A1C below 7 and the BMI below 40. Can you still have surgery? Yes, you still can have surgery. So it's not just one and done. You don't look at all those. The fancy term when you look at the world of arthroplasty is you need to optimize the patient. There are some people that we can never get certain things done, and we just have to keep working on that. Sometimes we have to work with an endocrinologist if it's an insulin pump. There's all types of factors on each person, but there's no just we absolutely say you can't have surgery, but there are certain things that we continue to optimize. Certainly if you have like an injection or somebody went through an injection series, we don't say you can't have surgery. We just say don't have any more injections, and then we'll see you back after a time period expires so that you do optimize the joint so that it has a good chance of having a good result. Is surgery with a robot more expensive? I would say maybe, and it depends on the type of robot. And so the robot that I just showed you, the answer is no. If the robot requires additional images, the answer is yes, meaning you have to go get a CAT scan or an MRI scan. So if you're considering that, make sure you don't have to get a CAT scan or an MRI scan because it is more expensive with that. But other than that, the answer with, again, the robot that I showed you, it is not any more expensive. So it's an excellent opportunity to have the latest technology without increasing your bill and actually have a better result. Certainly the results, if you look at the Australian registry in Australia. Most of those people have come up to our center and we've trained them, but they have a national data bank that they put all the results in. They're actually doing much better than the total knees, the ones done with the robot. So it's really exciting to see that this type of technology is improving our care. Another question is, any thoughts on CBD as an anti-inflammatory option? So CBD is coming into some prominence right now. We're seeing more and more of that. No double-blind study where we put just a cream without anything and cream with CBD on there. I don't think it hurts the joints by any means. And so if that's your pleasure, I think you can do it. I don't see that that in the world of arthritis that it's really curing arthritis, but for some people it may be helpful in taking the edge off. But again, we've not seen anything long-standing results that it's changing their world. But again, I don't think it hurts people. That's the first thing we have is do no harm. You can at least take a look at it. So how long, another question I have is, how long is the recovery of a total knee surgery? Well, it's a lot different than it used to be. You just saw the video of the lady who was walking out. You saw her doing steps within an hour and a half or so after surgery at the complete hip replacement of that one. But the knees are very similar to the protocol. So it depends on what you decide as recovery. But again, they're outpatient in my world. Even if you're 80 years old, they're outpatient. We do these protocols and we get people in and get them home because we feel home is the best place for them. But with that, you start out walking, as you saw, with a walker. And then we will see you back at around 10 days. And at 10 days, most people are off everything. I'm off my walker. I'm off my crutches. I'm off my cane. They just walk into the office. Some people even drive themselves to the office at 10 days. We start them on more physical therapy. They already are doing therapy. We kind of hit the up button and try to get a little bit more therapy for them at that point. I tell people to budget 6 weeks because I can't predict who swells, who turns black and blue. But at 3 weeks, and looking at our data, at 3 weeks, most people, not everybody, but most people, so that's over 50% of the people, are bored and like, can I go back to work? I'm bored. I've got a tea time. Can I go golfing? So we tell them between 2 and 6 weeks, and over 50% at 3 weeks are bored and wanting to do things. So that's what we're seeing with the new outpatient world with the robots and moving forward. How long do gel shots work? That's a great question. And again, there is some data about that. Again, I gave you a little bit of a hint on that when I was talking about the gel shots or the lubricant injections. If you're a candidate and you're successful in receiving those, it's about 70%. So 70% get better, 30% it doesn't change. It's not instantaneous, but 70% get better. If they do get better, it lasts about 9 months to a year. So that's the national statistics on that. So there are some people that do pretty well with it and they come in for an annual shot. And if their insurance company is approving it and they're happy and they're getting relief from it, we'll continue to do that. What you don't do is get a gel shot, don't get relief and come back and do it again. It does not make sense at that. So hopefully that answers that. Another question is, how long would I have to wait if I wanted to move forward with surgery? Well, it depends on each individual person. But, you know, people I saw today in the office, I was in the office today, some of those people were having surgery within 2 weeks from today. And again, it's individualized, depends on, you know, do you have people at home to help you there for a couple of days? Do you have a diabetic issue? Do you have a heart issue that we have to worry about? You know, we have to look at each person, but it can be as quick as 2 weeks. It can take as long as it needs to take. We don't do anything quickly and skip steps, but we try to do everything we can to make it safe. Another question is, would I be worse if I wait to have surgery? I'm worried about COVID. Well, the nice thing is, I get the concerns about COVID, but we've not seen one case at the hospital in New Albany. Thank goodness. We'll knock on wood. We've not had a case yet at the hospital. So it's been a COVID-free hospital, but we try not to even do them there. We try to even do them if we at all possible at the surgery center. So again, I respect people that are worried about it, but I would not delay care. We're actually seeing people coming in with bed sores and problems like that because they've gotten so deconditioned and they really did need surgery, that it's not an elective surgery. It's one that needs to keep people moving. The complications get higher the longer you wait. So each person's different, and that's maybe why you got to have a face-to-face consultation and have that good, you know, patient doctor, surgeon interaction. And I don't think there's any substitute for that. So don't let any news media or anything, you need to talk to people and find out, what your case looks like, what your x-rays look like, and what's best for you. How long until I drive? Well, great question. Assuming we're talking about knees again, it depends on which knee you have and whether you have an automatic or not. So if you're off, my 2 rules are you have to be off pain medicine. You can't take any opioids or narcotics. You have to be off pain medicine, and you have to be able to control your car. And like I said, I have some people that come in with 10 days and they drive themselves to the appointment. It was their left knee, they had an automatic, and they came in. So it just depends on that. And again, it's hard to predict who swells, what a person's pain tolerance is, how much black and blueness they have. But the implant is solid. You saw the lady going up and down the steps. So I'm not worried about the implant. I just want to make sure that you're safe and that the other drivers on the road are safe as well. So that's how we look at it from that. So I don't really ban people from driving. We just need to have a discussion on your safety and everyone else's. But the implant's solid right off the bat. What activities can I do after a total knees? What activities do you not recommend? I really don't limit people. I mean, the reason we do this is to let people have an active lifestyle. And so I let you do pretty much whatever you want to do. Would it be smart to be running 5K every night after you get your total knee? That may not be the smartest thing in the world. Don't become a knee abuser. But if you wanted to walk 10 miles a day, I'd probably give you a high five and say, I'm glad you're doing that. The more activities, the better. The knee was put in not to get babied. The knee is put in to give you a lifestyle and activity and be pain-free in what you're doing. So I don't really squash a lot of people on their activities. I have people that ski. I have people that play some tennis. I have people that play pickleball. I have, so I let people, again, I have to talk to them about what their desires are. And again, realistic desires, I think I don't try to hold anybody back on their activities post-knee arthroplasty. Next question is, I'm bone-on-bone osteoporosis. I assume that's osteoarthritis. Would gel shots be helpful, or am I looking at a knee replacement? So it really, again, it depends on your arthritis, your pattern of arthritis, how long you've had it, any other issues there. But in generality, again, I told you the gel shots are 70% effective, 30% not effective. Well, what's the difference? When we studied the people, why did the 70% get better and the 30% did? It's an obvious answer. The worse your arthritis, the less likely the gel shots will work. So you just have to look at your pattern. You have to look at your x-rays. And again, that's an individual conversation with your surgeon about how you're going to approach this and whether it's worth the expense and the risk to do either type of treatment at that point. So that's why you got to, again, I think really have to bank on having that interpersonal relationship and looking at your x-rays with each individual. Next question is, how long do knee replacements last? So the word on the street, which is wrong, is, oh, they only last 10 years and they have to be redone. So now we're seeing, 20-year results at knee replacements that have been in 20 years, 92%, 93%. We're seeing 30-year results. We're seeing 40-year results. So we don't put these replacements in to have them done and then have them redone. We want to do them and have them last the rest of your life. Now with that, you respect your knee. You don't do things that are, if something that you really value, you take care of, right? You don't take a crystal vase and throw it outside. By the same token, if you had a knee replacement and you're happy with it, you don't jump out of the back of a pickup truck. You would take a step down first. And so little things like that are just common sense in my mind. And I think you can look at, most of these lasting the rest of your life. That's how we think about it. And I think let me make sure if I have any other questions. If you have any more, keep putting them in. I've got a couple question boxes here, but I think I'm getting to most of them. Let me see here. Heather, do you see any that I'm missing?
No, I think that they've all been answered.
Okay.
Does anyone have any additional questions?
So if there are questions, you can let us know. You can always get more information. It's an exciting time with, the technologies and how we've been able to do things, even with the pressure of the COVID crisis, which has been, it was actually harder back in March, to be honest, because of some of the issues, but now it's not that big a deal for us. And so arthritis doesn't go away. It's like any other, it's a disability. It's the #1 disease we have for disability. So you don't have to suffer, and things have really improved. And so some people, I'm waiting for the next best thing. I think the next best things are here. Being able to do them in the last 10 years outpatient, being able to do them with the robots have really, I think, made the results better and the recovery much easier. So I'm full of optimism that we're seeing lots of improvements that are going to help people a lot. So another question came in as I was talking. Why am I still having pain after 3 months of a knee after replacement? And I guess I don't know. We'd have to look at X-rays and look at your course and what your pre-op X-rays look like, what your post-operative X-rays look like, any other factors such as stiffness, possibilities of infection, wound closures. There's a lot of things. It is a pretty complicated topic, but probably the best thing is at 3 months, talk to your surgeon. Maybe you're right on the cusp of breaking through, and maybe you have other issues. But it's certainly you need to talk to your surgeon initially and look for things that could occur. But like I said, usually we see people moving pretty quick through the process anymore. But 3 months, you may be at the cusp of just breaking through and need more therapy, but it's hard to tell. Each person is different on that. Any other questions? If not, I want to thank you all for participating. I thought we got some interesting topics and got some interesting, it's kind of interesting to see some of these Ohio-based companies that are changing the world on how we're coming up with new implants and new things. And certainly we're fortunate in New Albany that we've been the leader, nationally and even worldwide on some of these robotic and outpatient surgery. So I feel real fortunate that we're a part of that. So it gives me great optimism for all our patients that we can continue to help people and change their lives. There's still nothing better than someone coming in and said, hey, this has made a change in my life. I can do things now that I couldn't. I can be with my family. I can sleep, just simple things like that. So I'm real optimistic. I'm really happy that you took time out of your Wednesday night to be with us. And if you have any other issues, don't be afraid to give anybody a call.
Please, yes. If you have any questions, please feel free to give us a call at 614-890-6555. Our call center agents will be able to take care of your questions or get them to the appropriate person. And as Dr. Gittins said, I'd like to thank you again for joining us tonight. Thank you very much, Dr. Gittins, for speaking. We are planning additional webinars in 2021. More information to come on those. They haven't been scheduled. The time or the dates haven't been scheduled yet. So with that, thank you very much. Happy holidays and good night.
Good night. Thank you all.